the 15% that so-called partially respond. So again, even around that 8% success rate. A lot of studies around warm bloods and sport horses seem to get slightly higher success rates compared to racing thoroughbreds, which I guess we'd all expect from the loads that are going on. I guess one of the clinical benefits is this long-lasting effect, obviously with again, sorry, just getting some background noise there. Anyone else hearing that? Just check your video stuff there. Mute your microphone, that's okay. So then this long-lasting effect, and it's safe, it's proven safe now. There's multiple studies. It's been analysed by regulatory bodies. It's used extensively in humans. Similar, probably over 500,000 doses in humans now, mostly for tissue augmentation, but fully biocompatible and neuro-innocuous. And I would assume that somebody may sort of question this evening around this neuro-innocuity. Happy to talk about that in detail, but rest assured that this product is neuro-innocuous. So this is just a schematic representation of the integration process. So the slide on the left there showing once it's injected into the joint intraarticularly, it's this ability for it to exchange water molecules with the joint cap, synovial membrane, adheres to that synovial membrane, and then starts that integration process. Takes we know from 2 to 4 weeks, out to 6 weeks to undergo full tissue augmentation, and so it's this acting as a scaffold, allowing cell migration, tissue integration, and you end up with this thickened synovial membrane or augmented capsule. And what that does is provide greater elasticity and load transfer. These were some scanning electron microscope images that were taken. The one on the left is just the raw cell showing that tissue scaffold structure and the porosity and pore size there. The one in the middle, 42 days post-injection, showing that vessel and collagen integration with the gel. So it's fully biocompatible. The slide on the right there, really interesting. This to me was what we showed was the hypercellularity of the synovial membrane post-treatment. So it's essentially a new and improved synovial membrane. Now, unfortunately, we haven't sort of quantified what benefits that could have to the synovial joint fluid, but obviously we would theorise that it probably improves it. We did look at cytokine analysis, but we just didn't find anything convincing because we just didn't have elevated levels pre-treatment, and that's due to the daily diurnal variation in cytokine levels inside even a diseased joint. So I think certainly an area that we can have more studies in is to look at that quality of synovial fluid post-treatment. I think clinically what we see is the diffusion reduces and the fluid becomes more viscous, and so just a healthier joint. So where do we use it? We use it to manage joint lameness. It's this very precise therapeutic action on the synovium, which is giving you clinical benefit, improved joint function, and we certainly think it's modifying the disease process. And I think that's what's really exciting, that as a new style of treatment, we've been able to disrupt that cycle of hypersensitivity and sort of degenerative nature of arthritis that we know ends up in sort of end-stage disease and lame horses that we just can't manage and do anything with anymore. This was a graph out of Time Bar's work and published in 2016 in the goat studies. I think it's this increased actual elasticity even in osteoarthritic affected joints. So the top graph here, the gold or yellow line there, Australian gold, I guess we'll call it, that's the tensile strength to breaking of a it's an older slideshow. So have a look at this one here. This is a normal joint with the gold line there showing the elasticity. The orange line underneath is a diseased joint, so one that suffered from arthritis. So obviously that's more rigid, less flexible, less elastic, and that's obviously a clinical sign we associate with early stage disease when the joints are stiffer. And the graph on the there is showing a Arthramid treated joint. So in the purple line there, and that was actually an arthritic joint that was treated with Arthramid, and so that's even more elastic than your normal joint. So it's certainly this increase in elasticity that seems to restore joint function. The background there on the studies through from the early days, sort of 2012, the work started on the product. Worked with myself and Leigh Clifford did. So I'm still getting background stuff there. But yeah, we can obviously provide all those references as required. This is the study that's pending publication. So double-blinded positive control study. We put it up in 3 groups: the polyacrylamide Arthramid treated groups in the purple, triamcinolone treated groups in the aqua blue there, and the hyaluronic acid treated group in the grey. So the successful treated groups, this was at 6 weeks, showing greater efficacy of the Arthramid treated groups compared to the triamcinolone and hyaluronic acid. We studied the horse 2, 4, and 6 weeks. There was no difference between the groups at 2 weeks. There was a mild difference coming at 4 weeks, but a strong significance at 6 weeks. So I guess we'll go into a little bit of the case management there, which Emma and Leigh will talk a little bit more to. But following treatment, we definitely recommend the horses are rested for 48 hours. This is pretty standard practice, I guess, with any intra-articular treatment, and it's probably more important with Arthramid because it's quite a viscous product. We know that we get a mononuclear cell infiltration post-injection as the body starts to essentially react with the gel and start that integration process. And so, yeah, you definitely want to give that joint a chance to settle down. The key too is no point in injecting these horses and trying to crack on with them. You do want to give 2 to 4 weeks for the product to integrate and work. And I guess Emma and Leigh will talk a little bit more than that, but my impression is you can sort of get a better clinical result if you can actually rest these horses or just put them on the easy list, walking, swimming, light canter work, and not pushing them into full galloping work. The horses will show a gradual reduction in lameness and a concurrent reduction in reaction to passive flexion. We also see a tightening of the joints from anywhere from sort of 5 or 6 days, which I think is interesting, and maybe that's just the product coating the synovial sites and taking away that cytokine reaction. And then out to sort of 4 to 6 weeks where you expect no further improvement. So re-examining these horses at that time is pretty important to either reassess your diagnosis or even consider administering a top-up dose, a second dose, and those that may have only partially responded, because it just makes, if there's sort of a mechanical mode of action, you're going to get a dose-dependent response. These are sort of the dose rates that we've pretty much settled on. Again, no titration studies have been done on the product. It's not a pharmacologically active product. So really these are based on clinical results, and there's a effective study coming out of the UK, which is again pending publication, which shows down to only 1 mil was effective in a large number of horses in the likes of a carpal joint or a fetlock joint. And I'll let the others talk to a little bit more to that as to what dose rates they find most effective and what they're using in clinical practice, because obviously there's an economic effect around that too. This is not a cheap product, so you do need to be aware of how to sell it to the clients. And that's all I've got. So I'll just turn that off and come back there. Is there anybody who's got any questions at this stage, or happy that we move on to Emma's presentation? Just put your video on if you'd like to mention anything at this stage. Okay. Okay, Emma, are you going to start?
Sure. Hi everybody, I'm Emma Wood, Advantage Equine in Flemington. I just want to present a few cases. I've been using this product since 2016, and I've used quite a lot of it in different structures. So I'll start off with my first one. Oh, I need to open my sorry, just remembering how to do this. Okay, so first one is digital flexor tendon sheath.
You just want to screenshot.
Sorry?
We're not seeing the presentation there, so just open your share tray and share that.
Okay, hang on. Okay, you're seeing it now?
Yep, that's perfect. Thank you.
Okie dokie. So, yeah, as I said, digital flexor tendon sheath. So this guy is 8-year-old staying thoroughbred. He was sort of at the end of his preparation, last preparation, and he had mild to moderate effusion, no lameness and mild pain on flexion of that limb, but we were going into his final race of the campaign. So he raced well, and then went out for a short let up, and then went to a water walker and back into training. On resumption of galloping, this actually, it became moderate to severely effused just after doing a little bit of evens. Still no lameness, but definitely response to distal limb flexion. So he under saddle, the riders were noticing that he had a shifting gait at the canter and gallop. He was reluctant to lead with that forelimb and kept swapping and changing legs. The effusion definitely increased, like at the level of the fetlock and the pastern after fast work, and he was in very early race training. So I x-rayed the fetlock, no significant findings, and ultrasounded the digital flexor tendon sheath. I couldn't find anything other than a tenosynovitis, although, I couldn't rule out a longitudinal tear. So we gave the owners and the trainer the options of going for an MRI or a contrast study or tenoscopy, but due to the horse's age and where they wanted him to be at a certain time, we opted to go with Arthramid. I put 2 mil into the tendon sheath. The fluid was still a healthy colour, but it was copious and definitely with decreased viscosity. We're pretty time limited due to his racing program, so he only got to have 3 days in the pool. But in those 3 days, it had come down, but I just put that down to rest at that stage, and then he returned to full work. After 18 days, the tendon sheath returned to within normal limits. Now, this was after a jump out, and I thought if it was going to do anything within that short time, it would certainly start to get angry again after a jump out. But no, it maintained normal, certainly a reduced effusion, and you know, it had become much softer to palpate. So at this stage, we're 9 weeks into full race training. He's had three trials and a race, and no flare-up whatsoever. His actions improved, and the rider said that he's feeling better than ever. So yeah, that's the first one that I've done of that. So really interesting to see how that proceeds further on into his campaign. Okay, on to case 2. Can you guys see that?
Not yet. It's not coming up yet. I'm sure it will.
Might have to.
Yeah. It's certainly interesting that tenosynovitis, obviously not an indication that's been studied, but certainly an interesting case there. There we go. Yep, we got it now.
Okay. Okay, so my second case, hind limb TMT with a proximal suspensory. So this guy presented 3 out of 5 lame as in his spring 2-year-old preparation. I blocked it to the origin of the suspensory. He became even at the trot. He didn't go lame on the other limb. Radiology, he has sclerosis of the proximal MC3 and just mild lysis. On ultrasound, the cross-sectional area was definitely increased in comparison to the other limb. That colt went out and had a fasciotomy procedure and was then spelled for 3 months. He resumed racing. Came back into work and had a couple of races, and going into his 3rd one, he became 1 out of 5 lame. I treated the tarsal joint with triamcinolone. He improved, but he definitely wanted to lug in under pressure. He won that race. We returned him to the paddock for 4 weeks. On resumption of training, he was 2 out of 5 lame again. I did nerve blocks, and it blocked to the TMT joint. Radiology again, he still had this sclerosis of the proximal palmar plantar MC3 and just mild changes to that TMT joint. We sort of had a very set plan in his racing prep, and we did offer a scintigraphy and MRI, but they just wanted to push on. I put Arthramid in the tarsal-metatarsal joint, just 1 mil in this joint using a 19 gauge needle on the Lowe syringe that the product is presented in. He had 2 days in the pool and then just resumed just canter work at this stage. After 14 days, there was a really good improvement, and he was sound at 21 days when he started to commence fast work. He maintained soundness through that preparation. He had 2 trials and 3 races. He had 2 wins, and one of those was a Group 1. So that was a nice, successful outcome.
Yeah, that's great. Better than maybe the most that's going to happen. But.
Okay, can we see case 3?
Not yet. Back to the grey screen.
Okay, I think I have to. Sorry, everybody, technical issues.
The team's member.
Okay.
Okay, we've got it there.
Okay, so case 3 is just something that everybody is going to commonly find in racing thoroughbreds, third carpal sclerosis. I've treated plenty of these cases. I find that they crop up between 2 and 5 depending on whether they're racing at 2 or racing at 3. Definitely the majority that I find are sort of in their early 3-year-old preparations. They present with an intermittent grade 1 to 2 forelimb lameness. I find that they pull up from a gallop and they're lame, and then if you back off and put them in the pool for a few days, they come really good again. No obvious effusion, no obvious anything else in the distal limb. Then as soon as they have a gallop again, they go lame again. So nerve blocks, they block to the mid-carpal joint after 3 minutes, and they quite often swap to lameness in the other limb. On radiology, mild to moderate third carpal sclerosis. Occasionally, if they're presenting worse than what you're finding on X-ray, I'll always try and push for a CT, see if anything more sinister is going on. I like to spell these horses for a minimum of 8 weeks. It's really hard when you're trying to convince your owners and your trainers to do this, but with an ongoing lameness, I just find it futile injecting the horse at this stage. I think they really need to have rest, and you treat when you're coming back in. So if they're not getting the 8 weeks of rest, I try and push for, say, something like a water walker or beach or dressage, where it's just low concussion, and just try and get some sort of baseline fitness in these horses before they're training, they come back into concussive work. As soon as they come back into the stable, I Arthramid them straight away, definitely before you start galloping, ideally, like 1 to 2 weeks prior to galloping or to a trial. I put 2 mils in the mid-carpal joint bilaterally. If you're on your own and you haven't got a spare set of sterile hands, I'll quite often combine 2 syringes into a 3 mil syringe. So you're having to put 1 dose in. If you're doing that, I always use an 18 gauge needle so that it reduces the struggle to get this viscous product into the joint. I always treat on a Saturday so that they can have Sunday, Monday as easy days, and then sort of ease back into their preparations for the rest of the week. As I said, you want to do these while they're still just in light trot and canter work. So anecdotally, I've had fantastic results, especially when it's a mild to moderate onset, and there's you haven't got to the stage of bone loss and early fracture signs or anything like that. I certainly don't treat these horses with anything else. The 1 dose of Arthramid early in the preparation sees them through a prep. No lameness throughout. And as I said, if you do it early, it yields the best results. That was the end. I also find just with those, if you're treating them, these horses might have 6, 8, 10 starts during a preparation. And then if you can do them again on resumption of the next preparation, they just maintain their soundness just and keep racing soundly with no issues in that joint. Okay. Finally, I have subchondral bone disease in both front and hind fetlocks. Obviously, again, this is really common in racing thoroughbreds due to the nature of just our surfaces and the continuation of work. I find that they may start to pop up in their 3-year-old preparations, but the majority I find that really start to feel them as sort of when they're 5 and their training preps intensify and their paddock time is shortened and they're under a little bit more pressure to produce. So I think commonly what I find is that these guys come off the back of a really successful campaign, and they might have had a long campaign, but they've raced really well. and then they only get a short break, and then they come back in, and they've just got this horrible shuffly gait. They're shortened, they're aggressive in their work. I quite often find that they'll have internal EIPH, and I gather that that's pain related. They disunite at the canter. You know, you don't always get a fusion. You don't always get a reaction to flexion of these joints. If they're hind fetlocks, I find that they'll plait behind. You're getting speedy cuts, and around the fetlock and pastern area. Obviously, if it's unilateral lameness, then you just do your traditional process. But if they're just these, shuffly gaited horses, what I like to do is block the condyles and send the rider out just to trot and canter the horse. Like if they have regular riders, these guys know them best. So, they can come back in and tell you whether you're right or wrong. On radiology, you find flattened condyles, subchondral sclerosis, all types of DJG. If you've got severe ones, then you're going to find pod lesions, which are obviously going to be less successful if you're treating at this end stage. On scintigraphy, I've had a few scintigraphies done, and you'll get great big hot spots pop up on all 4 condyles. Best case scenario, you'd send these guys from an MRI, CT, or a 3D scan, but that's not always permitting. So again, I like them to go out for a spell. 3 to 4 months is the best possible outcome, but you really don't often get this due to the pressure put on the horse and the trainer. Racing around Australia's racing calendar, it's just really difficult to get that amount of time out in the paddock. And again, as with the knees, I like them to do that low intensity pre-training, so water walker, beach stuff, and then Arthramid them as soon as they come back into the stable. So I go 2 mil into the lateral pouch, and I do it with the limb non-weight bearing in front and hind fetlocks. These guys, if you can put them in the pool for a little bit longer, sometimes you'll occasionally get a flare. It's sort of for 3 to 4 days, but if you just box bandage ice and anti-inflammatories, they settle down within a week. I find same as the knee horses, if you don't gallop them for 14 to 21 days, you're going to get great results. At 21 days, that fetlock flexes really, really well. No pain, it's nice and tight, and the horses generally feel fantastic. So again, excellent results. They return to their previous performance. I don't use any other joint medications after this, just the Arthramid at the start of the preparation, and then again into the next preparation after they've had paddock time. And just incidentally, like these guys, I find that, post-gallop scopes, definitely a decrease in EIPH, or they stop altogether. So just, take-home message from me really is the earlier you get to that joint, the better. Just you're doing it when it's healthy, not when it's angry. Do routine trot-ups, just find them early. Always sedate them when you're using it. I find it can be difficult to inject, especially when the joint is tight. I find that 0.5 ml of dormicedin is enough, especially you don't want to give them too much if you're doing something like a hind fetlock, because you want them to be able to stand and not lay all over you. I always give a shot of bute, and I always give a minimum of 2 rest days. Okay, that's all from me.
That's brilliant. Thanks, Emma. That's great. I'll get Leigh to jump on and start setting up your presentation there, Leigh. I've seen a message come in from Michael asking around collateral ligament tears, and I'm pretty sure Leigh will talk to that in the next slideshow, Michael, so we'll probably answer that then. Are there any other questions at this stage, just while Leigh's getting organised? Okay. So, there, Leigh, you able to, yep, okay, great. Okay, yep, we can see that okay. So, Leigh, if you just wanted to introduce yourself quickly, and yeah, thank you, Emmy. You make some really good points there, which we'll come back to, I think, I'm sure, with the conversation afterwards. And probably, Leigh, probably, yeah, sort of 10 minutes would be plenty. Just whip through these would be great, and we can get to some questions.
Cool, right.
Yep, we've got.
Okay.
Yep, and see you, Joe. So that's over to you.
Okay, thank you. So yes, I work over in New Zealand, and I thought I would present some sport horse cases, primarily because all our good thoroughbreds go over to Australia, so we don't get a chance to use this very much in the thoroughbreds. And so first of all, I've got a 7-year-old warm blood stallion that was imported from Europe. It's used for show jumping with the view to go as far as it can, and sell the semen. So it was presented for poor performance in predominantly lack of propulsion from behind. Its ears were back. It was reluctant to jump. It had just gone sour. And when we looked at the horse, it was clear that it was lame behind, but it wasn't asymmetric, certainly enough to start throwing a whole bunch of blocks in, and even to the point where the old lameness locator was struggling to tell us what to do. So the owner said, go for a bone scan, which we did. And as you can see there, the TMT joints are pretty angry, in particular that right hock. And we were at the stage of the season when they were collecting this stallion regularly enough. And, again, we weighed up the options, and, the owners were reluctant to use any form of steroids, rightly or wrongly, on a potential effect on spermatogenesis. And so we opted to, went for the Arthramid treatment, and we put 1 mil into both TMT joint, and interestingly, in this case, there was more effusion in the left hock than there was the right. And that horse then went to a water treadmill for 2 weeks, and then back into moderate work, which consisted of mainly flat work, keeping it strong and supple at the same time. And then after 2 weeks, resumed jumping. And that horse, that was around about the October mark, and it went right the way through to our big Horse of the Year event end of March without any further complication. And that was this year. And the horse has been back in work for about 2 months now without any resumption of any issues. And we're looking to go for I suppose, a somewhat prophylactic injection in the next couple of weeks. So this is another show jumper. This is a World Cup level horse that did unfortunately qualify this year to go to the World Cup, but obviously it was canned. It's a 12-year-old warm blood gelding. He was reluctant to jump. He was grunting when he was landing. I'm not sure if that's because of the pain or the size of the jockey he was carrying. He was quite round. Probably didn't help things. And you can see just the the dorsal pouch of that coffin joint. You can see it's effused on this radiograph, but also you can see there's a little bit of medial lateral imbalance, and also really not much else going on. Toe might be a bit long, was well enough shod. So we just modified the medial lateral imbalance there, and we put 1 mil into this joint. So the reason why we did 1 mil is because over the last couple of years, I've been using it for about 6 now. And to be fair, the original research was looking at more refractory cases, and they were looking at 2 mils because those cases were either poorly or non-responsive to conventional therapies, which predominantly were either IRAP or just a TAHA combo, and they were using 2 mils. So I started off doing that, and then over time, I found that really when you've got really minimal or next to no clinically significant radiological changes, they're good candidates for a 1 mil into a majority of the joints in these sport horses, and the results are quite good. So this fella presented early January, and that's when the ground over here eventually goes hard, unlike kind of earlier on back in Australia. And yeah, he just got to the point where he just didn't want to go anymore. So worked it up, blocked out to the coffin joint, put the Arthramid in, and I'm very comfortable in doing that on the same day as we do the blocks. And then the owner of this horse is the bloke that owns the water treadmill that I spoke about in the previous case. So he had the ability to put this horse on it for, he tells me 2 weeks, but I don't quite believe him because the horse was out a month after this doing a World Cup round, and that was 2 seasons ago. And again, we just did a prophylactic top up before the season just gone, the 1920 season, and was no recurrence of the issue. So this pretty nasty looking joint here is a 16-year-old warm blood mare that was used for Grand Prix dressage, and had a prolonged history of joint injections that involved IRAP, cortisone. It did have a dose of mesenchymal stem cells injected into it as well, and we just weren't getting anywhere, and all they wanted was one more season. It was the horse's first season at Grand Prix, so the owner was really desperate to finish the season and make it through to that big horse of the year show. So this horse was 3 out of 5 lame, knew the history of it pretty well. And we decided to inject 2 mils into this joint because, as you can see, it's pretty severe changes. And we use a lot of meloxicam as well. And so this horse did have a 5-day course, and we used it pre-competition, post-competition for 3 days, in conjunction with hyaluronic acid IV injections as well, pre-competition. So it had quite a plethora of products. It was on Pentazan and also Epitalis. So you could argue, but there was on all of that before we had to do this. And then the only thing that changed was injecting the Arthramid into the joint. And this horse had 2 weeks off just in a small flat area at home on the grass, and then we brought it back in and built it up slowly. This horse did take 6 weeks to get there, but as you can see, the changes are pretty severe. But we got there, and we got the season finished, and the mare's now in foal, and the owner was quite happy. And so this is a 5-year-old warm blood gelding that was used for low-level dressage. It's about level 2 or 3 from memory, and it presented with 1 out of 5 left fore lameness that was on and off for about 3 months. And as a lot of people do, they feel that is it training, is it the surface, is the shoeing not right? So they went through a few things, and then eventually we got to see it, and it clearly flexed to the knee straight away. You could see it was moderately fused. It's not a very common joint to present in this signalement of horse, but nonetheless it blocked out. As you can see there, the dorsodistal tip of the radicarpal bone there, and it is pointed, it's sclerotic. And it blocked out. And we also did other diagnostic blocks to confirm that was the actual cause of the lameness, not any adjacent structures nearby. We injected 2 mils into this joint, and the horse was rested for 2 weeks, and then brought back in and went going. And that was 3 years ago. And the horse is now doing level 6, so your pre-St. George, and it hasn't had that joint re-injected since then. And interestingly, the horse is now no longer in our area, and the horse was, I think, sold about 2 to 3 weeks ago. And we presented these X-rays that were taken a long time ago, and nothing had changed since then, and there was no further injections needed. So that was quite a good win for everyone involved. And this view here is again another coffin joint, and you can see there's a bit of roughening on the dorsal aspect of P2 there. And this horse was a World Cup show jump again, 11-year-old warm blood gelding. It had a history of multiple coffin joint injections of of cortisone that unfortunately didn't respond. Okay. And so in the end, we put 2 mils into this joint because, as you can see, there's a few radiographic changes present. And within about 4 weeks, this horse was up and running again. This horse also went to the water treadmill and came back good. And that was approximately 4 years ago, this case. And we did the yearly top-up of only 1 mil because we're lucky that it hasn't recurred. We've got case 6 here. And we're fortunate enough in New Zealand to at least have one advanced imaging modality of CT. down at Massey University. And
Right, if you want to deal with it, oh yeah.
Okay, I'll be back. Yep.
That's screen. The and he's going to lock the screen on us too there. Okay. Okay, so while that's going on, has anybody got any questions? I mean, just turn on your video and jump in. And, oh, yeah, very quick. Okay. Right, back to you, Leigh. Just finish off this case and then we'll go to some questions.
Yeah, sorry about that. Wife had a seizure 3 weeks ago, so she can't carry him. So, where are we? Yeah, so we had a, on my presentations up, so I'll just go off the cuff, but this horse was a recent one. It was a, from memory, 4-star eventer. It was just off. It had been seen by several other vets. It would block out to the feet, but then we'd have a poor response to intra-articular triamcinolone, 10 milligrams. And then in the end, the owner said, look, let's just know what we're sitting on. So we were lucky enough to get a CT done, and the contrast imaging was able to show us some pretty significant synovitis that they deemed to be, fibrotic and chronic in nature. So we injected 2 mils into this joint and went through a standard rehab, went to the water treadmill facility that I've spoken about quite a lot in this presentation. 2 weeks there, and then back into dressage work for 2 weeks, and then the horses come back, and then COVID hit, so we couldn't compete. So it's first outings in about 2 weeks' time. So we'll see how it goes, but it certainly hasn't represented for any poor performance issues. And that's all the cases I had.
Okay, well, that's great. Appreciate that. Michael had a specific question before. Leigh would probably direct at you, that any experience with collateral ligament tears around that coffin joint with associated synovitis in the coffin joint?
Oh yeah, well, it's always the one of the conundrums, isn't it, when you get presented with the foot lameness? What is it? Especially when the synovitis is a primary or secondary. Yeah, I mean, I'm thinking, I'm assuming he's asking, can you put it in there if it's a tear or something? But it intrigues me, but to date, I'm not convinced. I think the only other structures you should be putting this into is a synovial cavity, such as a tendon sheath, like Emma spoke about, and I've certainly done that as well. I've done it 3 weeks ago, but I just didn't have enough time. It's certainly responding, but not enough to present about tonight.
Yeah, so probably be looking at blocking that joint, and if it responded to intra-articular analgesia, you might be tempted to do that, but you're probably managing the foot balance and the collateral ligament damage at the same time.
Yeah. I suppose there's another comment there in regards to that. I mean, I think, if there's synovitis as a result of OA, it's worth doing, but then, you've got to make sure you're going to get the primary problem sorted first. There's no point putting it in and spending all that time and money, and if your collateral ligament's going to be a significant stick in the mud.
Yeah, Chelsea's just put a similar post up there, not sort of specific to any joint, but around secondary collateral ligament damage. I think the only evidence we've got around that is probably stifles with meniscal tears, where Mark Kuhner in Germany seems to be getting pretty good results, doesn't he? Just with 1 mil in that medial femorotibial joint space. And whether there's some sort of soft tissue scaffold benefits. Again, anecdotally, we've had sort of response in Paston cysts and stuff, but I'm loath to say too much about that because I think we just don't know, do we? But,
no, I suppose we'll have to wait when now that the product's registered in Europe for human usage, I'm sure they'll be trying things out as well, so we better get some data from them.
Yeah. Is there anyone else that would like to come on and ask any specific questions? And seeing, just turn your video on. And jump in. I was just interested, Emma, you talked the scintigraphy and stuff. Do you have a good uptake with scintigraphy, getting clients to join you, to get it done? You're just on mute at the moment too, by the way.
Look, sometimes it's difficult. You do have to sort of really push for it, and depending on, you know, the level and the ability of the horse and what it's already shown or what we think it's going to show. But by default it'd be a wonderful tool to have done all the time, but that's not always the case. Yeah. But yeah, I have done a few, and they do light up like Christmas trees.
It's always difficulty, isn't it, in clinical practice, and I guess being at the coalface in a race yard with a trainer and a jockey and a racehorse that's got a campaign, owners, connections, etc. We're always under a lot of pressure, aren't we, to have an instant answer?
Yeah.
And sometimes and I know, you know, we do our best, but sometimes you do end up treating sort of diagnosis by treatment, almost, isn't it?
A lot of the time, and you're under so much pressure these days with these, you know, particularly with these better horses, and they are the ones that we're treating because we're financially viable to. But you're looking at, you know, a Melbourne Carnival, and then into, you know, potentially New Zealand, and then into Sydney, and then into Brisbane, and then back into Melbourne. Like, there's just no room for let up. So they, you know, and they want these horses racing all the time. So it does pose a real problem, and particularly it's hard to convince them if the horse isn't head bobbing lame. You know, it's and anyway, we just have to do our best. But I do find that Arthramid gives me the best results with our training program anyway.
Yeah, that's interesting. I mean, sort of looking back, I guess, over the 3 or 4 years you've been using the product, and sort of going through that education process almost with the trainers, do you use it differently now than you used to? And what's that sort of timing of intervention?
Very differently. And I think, you know, when I first started using it, I'd use it in angry joints, you know, like when they were sort of mid-prep or, and you would get a result, but compared to how I use it now, you're just getting far superior results when you're treating a healthy joint, or, you know, if a horse goes out with vetlock checks, you come back in, you treat it once, and I've had horses go on for 2-3 preps now just with the 1 dose of Arthramid, and just beautiful tight joints, sound winning races. So, and I sort of have it now where I'm treating early, I'm just getting far fewer. And like if you're diagnosing it towards the end of a preparation, you have the ability to give them that break and let the joints settle down naturally. And then when you come in and introduce the Arthramid early on into the preparation, you just get, you know, fantastic lasting soundness.
Yeah, and so getting the trainer on board to understand that and be patient and use it, allow you to use it at the right time.
Yeah, and that is part of the battle. But I think once they've seen the results, if you get it right the first time you're using it and you're seeing good results early, then it's much easier to then convince them to do other horses.
Yeah. No, it's really interesting. And would you say that you're sort of you know, dare I say it, sort of reducing your use of cortisone as a result?
I could almost say that I just don't use cortisone anymore.
Yeah, so that's got to be hugely beneficial to the welfare of the animal, doesn't it? And
absolutely.
Working with the racing authorities, it's exciting. Edwina's just tested in here, and I guess directed at both Leigh and yourself, Emma, but which are the main joints you have been treating with Arthramid?
So other than what I have presented, I've also done tarsicrural joints and stifles. And then, but yeah, predominantly you're doing fetlocks and knees.
I think it comes down to what case load you've got as well.
Yeah, absolutely.
As you can see, we get a lot of coffin joints in the show jumpers, and you get more, fetlocks TMTs with the dressage horses, and and the thoroughbreds are knees and a few fetlocks.
Yeah, and TMTs works really well in TMTs.
Yeah.
I suppose one thing that you said, Emma, about putting into a less angry joint, certainly from speaking to human tissue engineers, obviously a joint that's inflamed is in a catabolic state, and they certainly feel that when you inject the Arthramid, you will get a better response quicker, that will last longer if you're injecting it into an anabolic state, joint that's in an anabolic state. And if faced in a situation where a horse is lame and it's competing in a short period, but obviously still outside the withhold for, say, the likes of triamcinolone, then you can use it, get that horse through, and then wait. Technically 2 weeks is long enough for the immunosuppressive effects of triamcinolone to wear off, or a 10 milligram dose anyway, within a synovial structure. And then at the 2 week mark post triamcinolone, you can inject the Arthramid then. And I do that a lot because, as you said, not a lot of these trainers or riders will look at these joints every day and identify one that is angry but not causing lameness. So you kind of get caught at the end or at the bottom of the cliff. So it's a good way to get you out of trouble. And so by the time I think the clinical efficacy of the triamcinolone is worn off, your Arthramid's kicking in. And that raises another question. I've played with, and I'm sure people here know of or have tried injecting both triamcinolone and Arthramid at the same time. And so the one thing that, I find interesting is that, especially human tissue engineers, is that yes, you want the joint to be in an anabolic state, but if you're putting it in at the same time as a product that is immunosuppressive, and yet this product requires the immune system to be incorporated in the synovium, are you doing a disservice to it? And that's an answer that we do have some data on coming out of the UK, where they split quite a large number of animals. I think it's about over 100 or something into each group. And they found that administering triamcinolone at the same time didn't alter the efficacy of the Arthramid at all. But in saying that, the results were the same as using triamcinolone and Arthramid. So I'm sure we'll get some more ideas out of that data set shortly.
Yeah, it just seems very counterintuitive, doesn't it? And of course, I guess the big thing we'd all be concerned about was, does that alter with the withhold time on the triamcinolone, because you're augmenting the joint capsule. And I know people have asked that question before, and we don't have the science on that yet. But it would make sense to me that you're not administering them concurrently. But that's a nice segue. Dan's sort of asked here, Leigh, and again, I think you'd be the right person to talk to. What about non-steroidals concurrently with Arthramid? Obviously systemically. Any concerns that could interfere with the integration process?
Oh, I would say that a one-off shot, potentially not. But again, that's a very good question, and certainly in the last years, more specifically, reducing my usage of non-steroidals in general, because I think we can get into a habit of overdoing them, and as exactly like Dan said, there is good information. We need it to drive change, and that's what straining the musculoskeletal system to adapt to training is all about. It's actually causing inflammation to occur to get to a stronger state. So, I think a one-off shot, in theory.
Your experience, Emma, because you talked there about sort of pod lesions and subchondral bone disease. Are you using non-steroidals in those cases, or aspirin, or any other treatments?
I just find these horses at sort of end stage, like particularly in the racing horses, if they've got, pod lesions that are super visible, I think their careers are towards the end, and you have to manage them as best you can. And that is going to involve anti-inflammatories, and I certainly wouldn't cortisone a horse with a pod lesion, though.
Yeah. Non-steroidals shouldn't be a problem. They won't have the same chemotactic influence on cell infiltration, and certainly that mononuclear cell infiltration we see on administration of Arthramid. But I'm certainly concerned about concurrent use of triamcinolone. Again, another question here from Chessie, just to clarify, essentially able to use Arthramid in place of triamcinolone in most sport horses. We use triamcinolone, well, we were currently using triamcinolone. Would that be fair, Leigh? You just see it as a straight replacement. You're now using Arthramid instead of triamcinolone in your sport horse population?
Yeah, definitely. As long as obviously the timing logistics dictate, because I mean, again, how often do we see, a week or two before a big competition that the horse is lame? If the people can forego that competition, then yeah, I would definitely use the Arthramid first. And then if not, then we go through that scenario I went before, where you do just have to get the horse going for the owner if they put the pressure on. And then after the 2 weeks, when using a 10 milligram triamcinolone dose, then you can follow up with the Arthramid dose. And then, yeah, it'll be right from there.
One there for you. Where do you put the Arthramid when you're injecting HL origins? Is that suspensory?
Yep.
Origin?
No, I haven't injected Arthramid into an origin. I inject the tarsometatarsal joint.
Yeah, so that was that case you showed, and that's a classic presentation, isn't it? You've got a high suspensory, you block it, you scan it, you do all the work out, you go, it's a high suspensory, but there's that secondary pain, which often I think we overlook.
Because this guy, when I blocked him that third time around, when he went lame coming into that third preparation, he didn't block to the origin, he blocked to the tarsometatarsal joint. So that's why I put Arthramid in the tarsometatarsal, and then from then on he just went leaps and bounds.
Yeah. Okay. You also just joined. I'm afraid we might have got our time zones wrong. We're just about to finish up. But please feel free to contact us through the website, www.arthramid.com.au or .co.nz. And always happy to talk about cases as far as, we've got clinicians out there that have been using it for some time. I'm not in clinical practice now myself, but obviously sort of did it for 20 odd years, so still got a pretty good idea how it works, and obviously know a lot of detail about Arthramid, and coordinating with sort of a team of veterinarians globally, the likes of Mark Kuhner in Germany, Florent David, who now works in Qatar, Greg McCarroll and his team up in the UK with Andy Bay at Rossdale's, who's used it quite extensively now. He's just presented a small case series on navicular bones. I think the bottom line to me, it's an exciting product. It's got its place in the treatment cascade, and I think it's great. Really appreciate you, Emma and Leigh, sharing your clinical impressions of it, because I think we've learned a heck of a lot, all of us, over the last 5-6 years. And I'm sure we'll continue to learn something. So appreciate everyone joining us tonight. And if there's no further questions, we'll sort of sign off and let you get back to your families. Because, especially you, Leigh, you've got some babysitting to do.
Yep, that's for sure.
Okay, thanks for having me, guys.
Okay. I'm still here if anybody wants to